You're welcome to another episode of Meet the Practitioners on HealthAfrik, and this is AAU TV. This episode is brought to you by the Association of African Universities, AAU, in collaboration with the Center for Pregnancy and Childbirth Education, CPACE. Now, in our previous episode, we discussed what really happens at the neonatal intensive care unit, and as part of the discussion, we got to know that one of the concerns or one of the illness that leads baby to that unit is congenital abnormalities. And so in this episode, we'll be breaking down what actually it is. We'll also look at some common risk factors, and then what pregnant women as well as early mothers can do to reduce the risk, among many others. My name is Isabella Teta Hinakwa. We'll go for a quick break or we come back. I'll introduce our guest to you and start the discussion. Please stay tuned. You're welcome back from the break. This is Meet the Practitioners on HealthAfrik, and if you just joined, you can follow the discussions on our social media handles at Association of African Universities, both on Facebook and YouTube. And today we are discussing congenital abnormalities, and we are going to know what it is. We are going to discuss some of the common risks. We are going to know how mothers or pregnant women can avoid, or some steps they can take to prevent this. And we are privileged to be doing this with Dr. Richard Bright Daniel, who is a pediatrician at Kolebu Teaching Hospital here in Accra, Ghana. Hello, Doc.
Hi, hello.
You're welcome to Meet the Practitioners.
Thank you so much.
We are happy to have you here.
Very happy to be here as well.
Great. Before I can see the excitement. Now, before we start the discussion, please introduce yourself. Briefly tell us more about yourself.
Okay, so my name is Dr. Richard Bright Daniel. I'm a pediatrician, or if you want, a child health specialist. Okay. My mother facility is Whole Teaching Hospital. Okay. I'm currently doing some postgraduate training in Kolebu Teaching Hospital. I am an enthusiast, child health enthusiast. Okay. I am someone who is interested in genetics. I'm someone interested in neurodevelopment, and then also have interest in educating the public. So, in brief terms, this is me.
Great. Now, what actually pulls your interest in this field?
Well, it's important to note that children with congenital anomalies, whether we like it or not, they are there. They form 6% of births worldwide. Okay. Unfortunately, Sub-Saharan Africa bears a bigger brunt because we don't have the equipment and all to deal with them. Probably what we could do better is prevention. And once I got the information that we are having this very important discussion, I thought it was a good opportunity to engage.
Yes. Right. You're welcome once again.
Thank you.
Now, so we would want you to, let's start with understanding what congenital abnormalities is. In our previous episode, we got to know babies are born with it, and we got to know how it looks, but briefly tell us what it is.
All right, so we need to understand that when a man and a woman, the sperm and the egg meet, what forms is a small clot, like they usually say. Yeah. Now, this small clot is going to grow. It's going to grow very flat, then it's going to fold, and then parts will become the head end, and another parts will become the leg end. Okay. This doesn't happen for all children, and this doesn't happen in all pregnancy. So when this normal formation is stopped, or there's a problem, it doesn't become flat, it doesn't fold, it doesn't get long, then we say that the child has developed a congenital anomaly. Okay. Interestingly, there is no single definition for congenital anomaly because there are several schools of thought. Okay. Because there are things that you can see, and those ones are structural. So those are things you can see. The child's 2 eyes didn't form, only 1 eye formed. Where the nose is supposed to be is not there. Okay. The ears are not formed well. So those ones you can see. But there are things like the way the enzymes are supposed to work, you can't see. Okay. There are things like the way the child's blood is supposed to clot. Those things you can't see. Okay. So they are what we describe as structural abnormalities and functional abnormalities. Okay. So it's a very huge field. I mean, some terminologies like birth defects have been relegated because they thought it's denotes a negative connotation. When we say someone has a birth defect, like you have a defect.
Yeah.
So it's those a lot of new things, new technologies, but like I mentioned, WHO mentions that it's an abnormality in structure or function, or sometimes both.
Both. Okay, so if I understand well, we have the one you can see physically and the one within.
Yes.
Now, in the context of Africa, which ones are very common?
Well, Africa doesn't exist in a vacuum.
Okay.
Let me just mention here that some continents like Europe had long realized what we describe as neural tube defect. Now, neural tube defect is when you have an opening in your spine or in the baby's spine. So like I mentioned earlier, you all form from one ball, you flatten out, and then you fold. When this fold doesn't happen completely, you would have an opening at the back of your spine. And that's what we call neural tube defect. It's so preventable, and it's one of the, for want of a better word, the greatest atrocity you can do to your baby, making your baby develop a neural tube defect. And Europe, for example, have long realized this, and they've gone on to fortify foods, fortify cereals, fortify drinks, and all that, just to tackle this neural tube defect. So neural tube defects, for me, would be one of the common things that we usually will see
in Africa.
So again, just to mention that, like I mentioned about the definition, the classification is also based on which systems are involved. So the human being is divided into several systems. There could be problems with musculoskeletal, your skeleton and your muscle. So you could have your hands will be very short, it doesn't form at all. Maybe your fingers are attached all the way here. So that's a malformation. So that's musculoskeletal. Sometimes we see children who have problems with their urinary system. The urinary system is connected to the genitals. So together they form what we call a genitourinary system. You could have a problem with that. Such children may have their urethra opening where urine is supposed to pass out. It doesn't form well. The bladder, which is supposed to collect urine, is exposed on the skin, or the kidneys don't form at all. So we see some kidney problems as well. Then we would also talk about central nervous system. I've mentioned neural tube defect. We have some babies who are born with very big heads, which we describe as hydrocephalus. So we see those as well. Now you realize I'm using the word see because these are structural. These are things that you can easily see. And just to also add that not all congenital anomalies are visible at birth. There are some people who will start showing signs when they are 30, 40 years. So they are born with the problem, but they don't show you any signs. So they have 30, 40 years, they lose the ability to walk, their breathing becomes difficult, and unfortunately they may succumb to the anomalies.
Now, before we come to the signs, now amongst all these classifications or types, which one of them are life-threatening? Let's break it down to the two you made visible, and then the structure, and then the functional. So which of them is very life-threatening that if it is not treated, or should I say managed well, it can lead to the death of the child?
All right, so we have what we describe as major congenital anomaly and minor congenital anomaly. So your question is speaking directly to what we describe as major congenital anomalies. These anomalies are life-threatening. If you don't manage it, the child will die. So let me give you a personal experience. A child who is born and is not breathing well is rushed to us at NICU. We are assessing, then we notice that the child's nose is there, but it's not patent. So the nose is there, but the nostril is blocked. And that's what we describe as a choanal atresia. What do you need to do for that child is to make sure that you are getting air into the child whilst the surgeons come and retrieve or correct that anomaly. So that is a major anomaly. You have children who are born with maybe a very huge sac-like fluid here, compression on the airway. You need to drain that thing to allow the child to take his or her first breath. So those are major congenital anomalies. They are what we also describe as critical congenital heart disease. So we all know about hole in hearts. Some of the hole in hearts cannot stand time. We call them critical congenital heart disease because they are critical. The children would, or the newborn may succumb to that because the heart is not well
Functional,
formed, it's not functioning properly, blood is not moving where it's supposed to go to, oxygen is not being supplied to the rest of the body. So that's a critical congenital anomaly. So those are major examples of major congenital malformation.
Right. Thank you. So when we began, when you were explaining what this is, the congenital abnormalities is, you made mention, you started with a sperm coming together with the egg, and then you being pregnant, among other things. Now, during the pregnancy period, at what point or what time can these happen? I mean,
An interesting question. Yeah. So let me just run up with the major and minor. So the minor ones are things that are, for want of a better word, aesthetics. They just don't look nice. You know, someone having 6 fingers, 6 toes, so it's not nice. With just a little history, in history says that when a queen delivers a child, a prince or a princess who has 6 legs, it means, for example, that king is going to rule for long.
Really?
Yep.
Okay.
And then you would see that congenital anomalies have been depicted in a lot of ancient gods. So you see, if you go to India, for example, they have a goddess Kali, which is the goddess of death. It's multi-limbed, has plenty legs and plenty hands. So that's just by the way. The critical parts where congenital malformations or anomalies occur is in the first trimester.
Okay.
That is the first 13 weeks of pregnancy. And the most critical of that first trimester is the first 4 weeks. But interestingly, a lot of women don't even know they are pregnant because they are waiting to miss their period. And by you missing your period, that may be 2 weeks, 3 weeks, or 4 weeks in. And that is the very critical period where some of the congenital malformations occur. And that just to let us also note that they are what we describe the underlying causes of all this in the first trimester ranges for a number of causes. They are genetic causes. They are genes that have been handed over to the baby. They are environmental causes. The mother carrying the baby, the environment in which the mother is, the environment in which the child is, the environment that the mother is providing for the child, i.e. what the mother is putting in, and then even the environment in which the sperm that came to fertilize the egg was in, and both genetic and environment. So it's an admixture of a lot of things, but the most important critical period is the first trimester, which is the first 13 weeks of pregnancy. And even with that, the first 4 weeks, most critical.
Wow. A lot goes into it. Now, let's look at the signs. So this can happen within pregnancy. So what are some of the early signs a mother or an expectant mother will feel or see to know that there's something wrong? Maybe she's yet to go for an antenatal care. So at what point, or what are some of the signs they may see?
Okay. So interestingly, congenital anomalies can be picked up probably the first time the mother goes to have his or go to have the scans. That's the first time that the mother may know. However, if a pregnant woman notices that the pregnancy is 10 weeks, but the belly or the bulge looks like that of 38 weeks, it means that that baby has a lot of fluid surrounding him or her. What it means is that the baby is not able to swallow the fluid surrounding him or her. So we call that polyhydramnios. So that is one. Another way that the mother could also know is that the pregnancy is supposed to be about, say, 30 weeks, but the stomach looks like 18 weeks, just pregnancy. It means that the baby is not producing a lot of, as it were, water surrounding itself, and that's described as oligohydramnios. Or the mother noticed that the baby, the way the baby is moving, and if it's a mother who has had 1 or 2 children before, she can tell you that, well, the way the other babies were kicking, this one is not kicking, it's not kicking that much. So those are some of the early signs that you can pick. But importantly, there may not be any signs. And sometimes the scan may also miss it, because remember that it is operator dependent. It's the person who is operating it. he is going to find.
Yeah.
So if the operator is not, very competent,
Yeah.
might miss some of these signs.
Yeah.
So you see a mother coming to tell you, oh, I went into the antenatal, I went for everything. All the scans they said was normal.
It was okay.
But then birth happens and then there is a problem.
Well, all right, Doc, we'll go for a quick break. When we come back, we'll continue with the discussion.
Sure.
Please stay tuned. We'll be right back.
Africa is rising through knowledge, culture, innovation, and through our universities. This May 25th, African Union Day, we gather again. The Association of African Universities Television, AAU-TV, invites you to the African Academic Heritage Fair, AAHF 2026, a space where scholarship meets policy, student voices shape continental dialogue, where Africa's brightest minds and boldest ideas come together to drive Agenda 2063, the Africa we want. And this year, we are spotlighting the theme that touches every home, every school, every clinic, every community, assuring sustainable water availability and safe sanitation systems to achieve the goals of Agenda 2063. Expect a high-level dialogue on water security, sanitation, climate resilience, and human capital. A youth forum, because climate action starts local and youth are leading the way. A research and innovation pitch showcase, where innovators present practical solutions for safe water and sanitation to mentors, funders, and investors. And cultural moment that celebrates Africa's heritage, our identity, our pride. Mark your calendars for Monday, May 23rd, 2026 at 10 a.m. GMT. Join us in person at the AAU Secretariat, Accra, or virtually from anywhere in the world. Register now to celebrate African scholarship and own our future.
Welcome back from the break. Thank you for sticking with us. And this is Meet the Practitioners on HealthAfrik. And today we are discussing congenital abnormalities. Hello, Doc.
Hi.
Thank you for sticking with us.
Sure.
Wait, before we went for break, you made us know some of the signs a pregnant woman will see detecting that their child may have these issues. Now, let's say we detect this during pregnancy. What is the next step that the pregnant woman can take to ensure at least we are managing the situation or preventing it if at best?
Okay. All right. So this is a very ethical question. It borders on religiosity.
Okay.
There's a lot of ethics here.
Yeah.
But the options are, sometimes the pregnant woman is offered the option that you terminate the pregnancy, especially if it is found that the child has a major congenital malformation, which is incompatible with life. So, for example, you have a child whose head is so big, there's very little brain matter in there. When the pregnant woman is birthing that child, the pregnant woman may have some complications. So, sometimes termination of pregnancy is an option. Another time, there's what is described as fetal surgeries, where a surgery is performed for the baby whilst it's still in the mother's womb. We haven't developed expertise to that extent, but sometimes it is offered. Or sometimes the delivery is carried out close to where people can support that baby as soon as the baby is born. So, for example, I'm somewhere in deep down in the north. I've seen that there's a baby who has been delivered, the intestine or the esophagus is not patent, so saliva is not going down or liquor is not going down. So that baby, I would refer that baby whilst he's still in the mother's womb. So we call that in utero referral to Kolebu Teaching Hospital, for example, where you have people who are specialized pediatric surgery who can perform surgery for that child as soon as the child is born. So those are some help that can be given. Sometimes you need the baby to be born to fully evaluate the baby. For example, if I have a child who has a neural tube defect or a spinal bifida, I would want to see how much brain volume does this child have? So I'll do a brain MRI or a brain imaging, for example. I want to know, can this child suck? Can this child move the limbs? And then we can discuss going forward what we will do for the child. Because sometimes you need to know the full extent and what to do. So I've mentioned the things could be systemic, like could be a system, but there are children who have malformation in multiple systems. They may have problems with the heart, problems with the ribs, problems with the legs. So there are multiple, and it means that you need multiple teams to manage those children. So it's not a simple, straightforward answer, but in the we can mention this as options that are available.
Okay, so I believe you discuss with the mother or the parents and the family,
absolutely,
and then based on their convenience and comfort,
they are very key. So I had a mother who was diabetic, poorly controlled, didn't go for her antenatal. I'm not feeling,
I'm not feeling well.
I'm not feeling well. And I mean, even when she was told she was pregnant, still the control was very bad. I mean, fast forward, has a child who has multiple malformations. The heart is not well formed, both legs are not well formed, and all that. She can't take the child home because of stigma and all those. So eventually you need to talk to her so that she gets to know what we can offer for her and for her child. Unfortunately, that child died anyway.
Wow. Well, we'll come back to the stigma. Now, you made mention that sometimes it's seen during pregnancy, and also most times, I mean, you may not see it. The mother will go home, and that is when the child starts developing these abnormalities. Now, as a parent or a family member, what are some of the signs I will see in a child to know that, no, there's something wrong with my baby? He or she is not normal as usual.
Okay. I mean, we've moved away from birth defect and not normal. just by the way. But so let's just mention that one of the key things is having a thorough exam of the child in the hospital. A few times or sometimes people miss some signs. There could be a baby who is born without an anus, where fecal matter will go through. And if that baby is not examined well and is missed, what parents may notice is that this baby is feeding, abdomen is getting distended or bigger, but the child is not passing stool. And that is a problem. And that child needs to be seen at the health facility as soon as possible. Sometimes they are very subtle things. If you have a baby, you are not sure whether it's a boy or a girl, it could also be an abnormality. So you look at the genitals of your newborn, you're not sure, is this Kofi or Afi? Then there might be a problem, okay? You've seen your baby, you've had babies, you've gone to people's house during their babies, you see their length, how tall they are, and your baby looks a little squished or smallish, there might be a problem, okay? There are some babies, if you see them, if you've seen babies, you would know that there might be a problem, okay? Like a baby having a very small head. You will notice that, well, there is a problem, okay? So those are some things that people may be able to see.
Okay, with a small head, I know a parent will say, oh, for me, my child's head is very small and it's cute. I mean, they may think it is normal, but I mean, scientifically or health-wise, there's a problem with it. So I'm happy you're talking about this.
I'm sure you've heard about Zika virus. It's gained some traction earlier in Brazil. So it's caused by a virus, and most of the children are birthed with very small heads. They are familial small heads. People who in their family, their heads are small. Those, we are not talking about that group. We are talking about people who, because the brain probably didn't form well, or the protection of the brain, which is the skull, had closed earlier than usual. So those are the group that we are talking about.
And also, I'm happy you talked about babies' examination before they are taken home. This also appeared in our previous discussion with another doctor. And I learned, or we got to know, that it is an option. However, parents need to pay before their baby are fully examined to ensure everything is good before they are taken home.
The common practice now is that every baby is examined by a doctor a midwife may also look at the child, but the doctor finally says that, okay, take your baby home.
Okay.
So that is the practice.
Okay.
That is supposed to be the practice.
Okay.
I mean, but what I want to emphasize is that examination again is a skill. It's something that you should want to do, and you should do it well. So in the same way, you could have a mechanic who will fix your car, continue fixing your car, but the problem persists. And you take it to another mechanic who takes his or her time, looks thoroughly, and fix your car. You know that now someone has fixed the car. So sometimes there may be, I mean, it's not supposed to happen, but there may be that differentiates of examination potential. So yes, it's something we are talking about. We keep mentioning it. Younger generation like us are supposed to continue to learn the skill, how to examine and pick up subtle signs of congenital malformations in children.
Great. Now, in our context, we see how family members, parents, and even the child, what they go through being born with this. The stigma, the definition, the names, like a whole lot goes on. You made mention that some parents may even not want to go back home with the child due to the stigma. How do you address such situation? You know, mental issues, finance, and how do you address this issue and ensure that, I mean, the parents and the family, they are okay before they leave the hospital?
It's a very complex situation. There are a lot of ethics in it. We had a child who was birthed with what we describe as an unfallow cell. So the umbilicus was very huge, covering almost the abdomen. You could see some organs in the abdomen, so the liver, you see the intestine and all that. And this man was supposed to be made a chief in the coming week. So he was in confinement and now has a child. And definitely if this child goes home, they will probably bring him out of confinement without him becoming the chief. He sends envoy over with instructions. Please do away with the child. So sometimes those things come about. In Ghana, there are no laws concerning euthanasia. You would not kill someone's child because they ask you to do it. So there's no law backing that directive. So most of the time, what you need to do is to continue providing compassionate care for the child, and then get the parents to come around. And inform them, this is it, this is what is going to happen. Sometimes we call something comfort care. You notice that this child has so many anomalies, different systems. Operating one, I mean, the child may even die earlier than if you leave the child alone. So the parents need to understand what is happening. And then together as a team, you decide, okay, we are going to do this. We are going to feed. We are going to help this child feed safely. You know, we can do some compassionate care for the child until if the child unfortunately dies, then I mean that is it. But we will not advise, as it were, fast track a child's death, for example. So that is one of the ways. One of the key people in this discussion are the parents. We need psychologists, so there are psychologists in the team. You need doctors who also understand, and you need nurses who also understand, because some of the children, because of the malformation, they may not be able to feed as fast as other people, as other children. So you need to take your time. You need to pass a tube, make sure the tube is always in place, you know. So there are these little care skills, compassionate care skills that each of us need to develop. And that is what is important. We are having this discussion. Families should know that such children may be born. They may not be discharged the next day. They may need longer times in the school, so in the hospital. So it is important we need to have this discussion.
Right. Now, so we understand babies are born with this, and it is genetics. It is passed on to them, among others. Now, I believe you made mention there are some environmental factors that can also, lead to the situation, and lifestyle. We have parents who will be doing things that they are not supposed to do, that they are pregnant and all. Can you let us know some of these lifestyles or some practice we do that at least can lead children to that?
All right. So in 50% of cases, we don't know the cause.
Okay.
In about 10-20%, we think there may be some genetics.
Okay.
The rest, we are talking about environments.
Yeah.
And I've mentioned things like maternal illness, diabetes, one of the very common causes of congenital anomalies, and the mother needs to have appropriate treatment for management for that. So maternal medical condition, diabetes. A mother who is on medication, so medication like anticonvulsant, anti-seizure medication, if that woman is planning on getting pregnant, he needs to stop the medication for 3 months before she gets pregnant. A mother who is taking alcohol, it can give you any problem in any of the systems.
Yeah.
So women who are in childbearing age, who are doing things that can get them pregnant, alcohol is not your friend. Okay. Smoking, one of the big environmental factors we need to talk about. Of course, keeping pets even around for a pregnant woman is not ideal, because some of these pets contain, when their fecal matter, their feces contain things that can harm that baby. So those are important things that in the pregnant woman needs to know, and then the environment needs to know. Increase in maternal age, mothers, women are, career and all that. Once you hit 35, your risk of having a child with some congenital anomalies goes up. And fathers are not left out. When you hit 45, the risk of you having a child with congenital malformation also goes up. The work one is doing, if you are exposed to heat, intense heat, is been said to be linked with some congenital malformation as well, including fathers who are working with fire service, exposed to very intense heat. Protection not optimal. So all those things can be linked to that. I've mentioned smoking. We've mentioned alcohol, which we need to stress. But women who also do not take in folic acid, and now folic acid is what we give pregnant women when they go for antenatal. Ideally, if a woman is expecting to get pregnant, you should have started folic acid 3 months before you get pregnant. So even starting folic acid early is one of the ways to prevent the congenital anomaly. So if you don't start it early, your risk goes high.
Well, let's continue with the discussion of things we have to do even before getting pregnant. You made mention of folic acid, taking in folic acid. What other things should a mother expecting to be pregnant or preparing to be pregnant to do to ensure that they give birth to a very healthy, normal baby?
Obviously, if there's any medical condition, it needs to be managed well. There's basic. If you avoid any of the social vices, we've mentioned smoking, we've mentioned alcohol. So those are things that you can do. I mean, definitely, once your health is cleared, you make sure you are not exposed to any of the things we've mentioned. Sometimes people are on treatment for certain cancers, for example. You need to talk to your healthcare practitioner so that the pregnancy is planned, because this is very important. Remember that when we talk about the ball and then the flattening, things are multiplying, they are growing very rapidly. So if anything disrupts that growth, then there's a problem. So those are things that we can do.
Well, we've heard it all. I mean, as you are planning, childbirth is between the mother and the father. But then, as you are preparing for, you need to see a doctor and preparing to give birth. What are some of the things that you do? Some guidance, from the doctors is going to ensure that we give birth to a healthy and normal babies. All right, so Doc, we would want to know which of these the types or classifications of congenital abnormalities, which of them can be treated, corrected, and the ones that nothing can be done until it's a lifespan thing that nothing can be done about.
All right, so I've mentioned major and then minor congenital anomalies. If I have a child who has a little stump, an additional limb here, usually the nurses will just tie it off and then it falls off. If this additional stump has bone, has flesh, has muscle, then surgically it will be removed. So those ones, once it's removed, that is it. There's no other concerns. Sometimes some babies are born with what we describe as dysplasia. Dysplasia is like very big word. It's like eye. You can find the eye hair at the inner region of a child. So it's not, you don't expect eye there. So
of course.
That's a problem. So those are what we describe as sacrococcygeal teratoma. Very big word. But those ones need to be removed. It's more like it's it's like a type of cancer or tumor.
Okay.
So those ones need to be removed. Okay. Now I've mentioned cystic hygroma, the sac-like swelling here, a lot of fluid. Once you drain it and then some dye is injected into it to close that potential space, that also saves that child. So those are things that could be worked on. There are some heart disease that the child needs to attain a certain weight before it could be done locally here. So for those children, they are given some medications to help aid the heart. I mean, the heart keeps going until the child attains a certain weight, and then the child can get some intervention done. So it depends on what it is. But some congenital anomalies can't wait. If I have a child whose intestine is not patent, food is not going to go through. So that child needs to be seen and operated on ASAP.
Okay.
How would this child be picked up? This child may be vomiting all the feeds. Vomiting may be very yellow. The child is not passing stool. Abdomen is very big. You don't have time. That child needs to be fed, seen, and then surgically operated on. So those are options that are available. If you had the child I mentioned about someone with multi-system, I mean, sometimes it's just difficult because you may not even know where to start from. The child may not withstand anesthesia. I mean, nothing could be done. Okay,
now before we wrap up, so does that mean that all type can be solved? I mean, it can be treated, and there's none that, I mean, it is till death?
So it depends on what the baby has. What the evaluation shows. If I have a child, I have an imaging done of the brain. There is no brain. We can't transplant a brain to that baby. So that is difficult. If I have a child who has a cleft lip or palate, the top of the roof of the mouth is open. That can't be repaired. So that child could have a repair done.
Now, has there been a situation where, let's say, you cut the limb off and then I'm just asking for someone, it redeveloped, or maybe the fluid here we drain it and then it developed? Has there been a situation where
so usually it's not like once you do that you are off. You'll be seen to be re-evaluated and see whether there's any recurrence. But usually once it is off, it is off. You may have a little stamp there. Some people, the body will resolve it with time. And that is why when the fluid is drained, for example, the space is not left. If something is injected into it, so that now it will close up. So there's no space for any fluid to recollect, for example.
Right. So a parent watching us now is going through this, and I mean, he or she understands what you're saying. And there's another one also watching us who doesn't even know anything about it, but has learned a lot from this discussion. What will be your final words in terms of motivation, in terms of what to expect, in terms of when they are diagnosed of this, what should they do? I mean, some words of motivation to our parents watching us.
Well, so I would say the first thing is that any expectant mother, any woman childbearing age, planning to get pregnant, like I said, the word is planning. You need to plan with your healthcare worker. If there are any medical conditions, that need to be taken very good care of before you get pregnant. Secondly, the environment, exposing your growing child to environmental toxins is a no-no for a pregnant woman. And more so, like I mentioned earlier, you might not even know you are pregnant, but that very 3 weeks, 4 weeks is a very critical period that if this child is exposed to anything, the child may have some abnormalities. So I think that can be our takeaway. We cannot end this discussion without talking about folic acid. Before you get pregnant, you make sure you're on folic acid 3 months before you get pregnant.
Right. Thank you very much, Dr. Janu. Thank you so much for sharing your insights and educating us on this. We appreciate it, and we hope to see you again on our next episode.
All right, sure. Thank you so much.
Great. And this brings us to the end of today's discussion, which is congenital abnormalities. You've heard it all. It can be prevented, and also when diagnosed, it can be treated. So see your healthcare and have some discussions with them. My name is Isabella Tetahinakwa. See you again in our next episode. Have a great day.